a combination of olive oil drops and sodium bicarbonate drops, but it got to the stage mid last week where they were experiencing extreme deafness and some altalgias, or some pain in the ear, and they arranged to see me this morning. Starting off with the right ear, and you can see it's quite evident that the patient has been using drops for a long time. The wax is, the sodium bicarbonate drops tends to bleach the wax and dead skin, turning it from a brown to a pale yellow, almost a whitish appearance. And you can also tell by the colour of the ear canal, it's slightly pinker than it should be, so it's slightly inflamed. Now, could be one of two reasons. The patient may be suffering from what we call otitis externa, which is an infection or inflammation of the ear canal wall, but it could also be due to the excessive use of earwax drops, and in particular sodium bicarbonate drops. So sodium bicarbonate earwax drops are water-based and they're slightly alkaline. The ear itself is slightly acidic, as is earwax, and sometimes if you use these water-based alkaline drops like sodium bicarbonate drops or hydrogen peroxide drops, they can cause a bit of a reaction within the ear canal. So we've advised the patient to monitor his symptoms. If he's experiencing any itchiness or any pain after the wax has been removed, to contact myself so we can recommend some treatment and write a referral to his GP. But I suspect in this case it's just because of excessive use of drops. You can see you've got a large chunk of earwax there. So the ear canal is more or less clear now. In the distance you've got the tympanic membrane, the eardrum, and there's just some soft wax and dead skin. So I know a lot of viewers really enjoy the skin peels. They've become very popular. We don't always remove skin. We only remove skin if the skin is ready to be removed or it's infected. And sometimes when we hover over the ear canal wall, like particularly in this case, actually, it's a prime example, you get skin that naturally just kind of retracts and elevates itself from the canal wall, and at that stage I tend to just continue to remove the skin because I don't want large tails of skin in the ear canal that are flapping around. However, if the skin is not ready to be removed, we leave that there. So another drawback of excessively using earwax drops, that it does really make the skin that coats the ear canal quite soggy, and then all the dead skin itself, it is ready. It's very sloppy in consistency, very mushy, and it peels off very easily, like in this particular client. So what I was trying to do is just hover over the ear canal and just remove some remnants of soft wax debris that was still remaining. But then the skin, because it was quite soggy and wet, it also detached itself from the ear canal wall. So I'm just using a fine end gauge here, just gently lifting the skin. And you'll see in a moment, I removed quite a large piece of dead skin from the anterior canal wall, which is the front part of the ear canal. So on view, it's the right hand side. So again, I'm just trying to remove some of this remnants because it could be otitis externa, and this could be some otorrhea. So otorrhea is ear discharge, and sometimes it's difficult to differentiate between otorrhea, so ear discharge, and earwax and dead skin that's been discoloured and bleached using sodium bicarbonate drops. And that's because both ear discharge and softened debris and dead skin and wax, because of the use of drops, is a similar colour. Another hallmark of otitis externa and otorrhea, so ear discharge, is that you do get a very pungent, almost really acidic smell from the ear, which wasn't really apparent in this client, hence why I just believe his ear canals just become a bit sensitive to the excessive use of drops. And here's just dead skin off the anterior canal wall. And again, we're not trying to remove every little last flake of dead skin. We're just trying to remove this big flap of dead skin because I don't want it to flap around in his ear on a windy day, and he can feel it flap around, which can happen. And also with skin, we just have to be a bit careful because it can clarinet. So the skin gets lodged and trapped at the entrance of the suction probe, and it flaps around. And it emits a very high frequency, almost deafening whistle. So, and that's generally why I use a fine end gauge, because it minimises the clarineting. just a bit of dead skin there. And again, I'm not trying to remove every little last speck. That's not what clinical ear care specialists do. So that ear has been fully treated. We're just going to the left side. So the patient hasn't been using the drops as much on this side. So you can see the wax is not as soft and soggy and wet as it was in the right ear. But there's a lot more skin adhesions here. You can see there at the base, just at the bottom underneath this big plug of wax, a thick layer of keratin. So that keratin is shedded. It's dead keratin that's been shedded from the ear canal, but it's also attached to the wax, and we just have to maneuver this plug of wax to loosen that dead skin, detach it from the canal wall. And you see the method I use to detach dead skin. I'm getting a suction grip and I'm just making little wriggles upwards and downwards, sometimes in circles. I tend to find with dead skin, I don't generally rotate it in circles as much as I do for wax when I'm trying to loosen wax, but you can see there's a few concentric circles, clockwise motions, and these movements just help tease the wax and dead skin off the ear canal wall. And whenever you've got dead keratin skin in the ear canal, it does make the procedure slightly more tricky because the skin is attached, some of it is still attached to the ear canal wall, it's attached to the wax, so it's almost a tug of war. The ear canal doesn't want to let go of the wax, hence why we have to almost wrestle it out. There we are, I've got a large piece of dead skin and wax there. And you can see the tail end of the keratin. So this keratin's a bit more crusty. It's not as wet and soggy as it was in the right ear. And that's because the patient hasn't been using drops in this ear. He was just using it in his contralateral ear, the right ear, sorry. So again, just some keratin there that I'm just trying to loosen. The more medial part of the wax and dead skin, so this is further in the ear, it is slightly more mushy, and I suspect that's the humidity. Obviously this ear canal is completely occluded, it gets warm, it gets moist, it gets sweaty, and it can make the wax a bit more mushy in consistency. Also, when you use Otex, not only Otex, I should say, any drops that contains hydrogen peroxide, it also can turn the wax or dead skin into this mushy consistency. It's best compared to like mashed potato. So what I've done, you could see the suction probe was getting blocked with this soft mushy debris. So I just put some olive oil drops into the ear canal. This wax is quite deep, it's probably 2 centimeters within the ear canal. I've just put enough olive oil drops there just to soak this wax for a few minutes. I'm just rotating the ear, so if you were watching me perform the procedure from the outside, I was holding on to the client's ear and gently just turning it in circles, rotating it so this olive oil can really get in behind this plug of dead skin and wax. And you can see that keratin, so it's unmistakable. It's a white glossy colour. And it's still a bit mushy, but I am getting a better grip now. I'm just trying to loosen it from the canal wall. There we are, so I've loosened it from the anterior canal wall. So the suction probe is blocked there. You can just saw me wriggling it, shaking it, trying to unblock it. And it did unblock without me having to remove it and using a cleaning rod to kind of shove through it. It's blocked again there, but it just unblocked itself. There we are, I'm just gently bringing this plug forward, so a bit of soft dead wax there blocking the tube, so I had to come out there and clear that up. And that's the remaining large piece of wax that's separated in two as I was removing it. So the ear canal is completely clear here. Now there wasn't any need for me to do a skin peel here. There is a bit of dry skin around the edge, so I am going to mop up, but the skin was not ready to be peeled and removed. It was still attached. The majority of the dead skin came off alongside the wax. So this is the undergrowth of kind of a fresher layer that isn't ready to be shedded. So we don't, as I said, it's very important to realise we try to avoid removing skin unless it's absolutely necessary. So for me, to remove skin, there's 2 reasons why I remove it. If it detaches itself during the procedure and it's flapping around in the ear, I try and remove as much as possible. Or if the skin is infected, which it isn't in this case. So I'm just mopping up near the entrance some of this wet debris, and you can see the skin is not coming off as it was on the other side, so we're just going to leave that in a moment. That's not going to cause the patient any issues. It's not a large enough flake of skin to flap around. There's the patient's tympanic membrane, slightly opaque in colour, missing a light reflex, but we generally find that in older clients. That's all the contents on both ears. I hope you enjoyed that video, guys, and I hope it kind of makes a bit clearer as and when we remove dead skin and do skin peels. If you're watching for the first time on YouTube, please do subscribe to the channel, plus the bell icon so you get notified as and when I upload new videos. And if you're watching on Facebook for the first time, similarly, follow the page, and hopefully I'll